Good afternoon, everyone. On behalf of DocPlexis, this is Dr. Shatil from the Clinical Engagement team, and I welcome you all to today's special webinar organized on the occasion of National Childhood Obesity Awareness Month. Our theme for today is Childhood Obesity Epidemic, Clinical Insights and Community Solutions. Childhood obesity is one of the most pressing public health challenges of our time, with far-reaching effects on both physical and emotional well-being. As healthcare professionals, it is crucial for us to understand the clinical dimensions, preventive strategies, and community level interventions that can help address this epidemic. We are truly honored to have with us Dr. Prashant Salvi, a highly respected name in the field of bariatric and metabolic surgery. Dr. Salvi holds an MS in general surgery, is a fellow in minimal access surgery and advanced laparoscopic surgery, and has completed a fellowship in bariatric and metabolic surgery. Currently, he is serving as a consultant laparoscopic, metabolic, and bariatric surgeon at Jupiter Hospital, Thane, Pune, and Indore. With over 2,000 bariatric cases managed, Dr. Salvi has earned recognition for his meticulous decision making, dexterous surgical skills, and excellent management of obesity. He is an active member of prestigious associations, including the Surgery Society of India and the Association of Surgeons of India. Dr. Salvi's contribution to research are equally remarkable. His study on the banded sleeve versus MGB OAGB was selected amongst the top three publications from India at the OSSI Con 2020, and his numerous award-winning video and paper presentation at OSSI Con 2019 and ASI Con 2022 highlight his expertise and dedication to advancing the field. We are privileged to learn from his insights today as he sheds light on both clinical approaches and community-driven solutions to childhood obesity. Please join me in warmly welcoming Dr. Prashant Hansraj Salvi. Welcome, Doctor.
Thank you so much, Adil. Thank you for a lovely introduction. And what Doc Plexus is doing, it's really commendable because obesity itself is a major, rather than epidemic, I call it a pandemic now. And concerning childhood obesity, yes, it's a I mean, as we go ahead in the presentation, you'll understand why I am so much for childhood obesity. The day when you called me and said, no, can you do that? I was so happy that, okay, now, because that awareness is really important. That awareness has to be spread. And the way childhood obesity is on a rise is a disastrous thing. So, without wasting much time, I would just go on with the presentation. And the theme of this month is childhood obesity. So, based on that theme only, we have discussed and we're going ahead with the childhood obesity topic. So, good afternoon, everyone. I would rather introduce myself as a bariatric surgeon operating at Jupiter Hospitals. I do bariatric and metabolic and robotic surgeries also. So when you see, one second, yeah. So we all know that obesity itself is a global burden, and it's a global pandemic. And when you talk about obesity, we are talking or we are hinting on an elephant in the room, which is rightly depicted in this meme also. That yes, there's a big elephant in the room, and the mother still considers the baby boy as a big elephant. But yeah, pun apart, it's a global burden. If you see what the figures have shown, worldwide obesity has nearly tripled since 1975. And most of the world's population living in countries where obesity and overweight kills more people than underweight still. I think 200 years back, Benjamin Franklin had mentioned that many die of overeating and then as compared to people who are dying of hunger, which is still true now as well when we look at the documents or look at the data like that. So over 340 million children and adolescents aged between 5 to 19 are overweight or obese, which was seen in 2016. 38 million under the age of 5 are overweight or obese in 2019. And when you see the data which is there today, India will have more than 27 million obese children by 2030. And are we ready to combat that? That is the question. And these figures are really, really alarming. In India at present, if you see 5 to 8.8% of school going children are obese. And if we consider everything as a disease, we should also know that obesity is preventable. So, today in the lecture, we are going to assess what are the reasons for obesity, how we can combat it, and what are the multiple options through which we can combat it. So first, we have to define obesity. Now, when you talk about adults, the BMI, the body mass index, is a simple index of weight for height, and that's for adults. But for children, let's say for children under 5 years of age, we have the World Health Organization child growth charts. And when you see overweight, or when we define overweight, it is the weight for height greater than two standard deviations above the WHO child standard median. And if you see how we can define obesity, it is the weight for height greater than three standard deviations above the World Health Organization chart of growth median. So if you see for girls, this is the chart for girls where one, if I can draw the arrow, so this is the standard median, and two for standard deviation above is overweight, and above three is obesity. That's same for boys. This is a normal, this overweight, and above three is obesity. Now, for what patients or children who are above 5 years and lesser than 19 years, wherein how do we define that? Overweight is defined for BMI for age greater than one standard deviation, and two standard deviation is defined as obesity. So, if you correlate with BMI at the age of 19 years, overweight above one plus standard deviation comes to around 25 kg per meter square of the BMI. Or if it is obesity more than two standard deviation, it is equivalent to a BMI of 30 at the age of 19 years. So that's the chart for BMI for age for girls between 5 to 19 years of age. So this is the standard deviation. This is overweight, and that's obesity. Same for boys, that's the normal median, and two standard deviation above is defined as obesity in patients or children between 5 to 19 years of age. Now, for children between 5 to 19 years of age, there is a weight classification also. The same classification, the WHO classification for adult is also available. So, based on that, we do have weight classification for children between 5 to 19 years of age, wherein underweight BMI is for age is less than fifth percentile, healthy weight, which is normal weight, which is BMI between fifth percentile to less than 85th percentile. And as we go between 85th to less than 95th percentile, it is overweight. And above that, this is class 1 obesity, severe obesity class 2. So for severe obesity class 3, a BMI of more than 140% of the 90th percentile, or BMI greater than equals to 40. For severe obesity class 2, which is BMI 35 to 40 or less than 40, which is class 2 obesity. So these are the different weight classification based on which we understand where your child stands, or where a population. So where a population at mass, we can calculate the BMI, and based on that we can define obesity, and then we can assess at large how many children or how many people are suffering from overweight, or how many have obesity which is defined. Now, looking at the causes for the present obesity epidemic, we all know what are the causes. We all must be knowing more than what is written on this slide also. The basic thing is the energy intake is far more higher as compared to the energy output. And the reasons is because of the decreasing physical activity. There is increased consumption of high calorie food. There are more meals which are taken outside rather than consumed at home. And there is increasing portion size. There is also a lack of concern about obesity, because if you see common examples, if you see both the parents are working, there's hardly any time for the parents to devote what the child has to eat, so they are more for the processed food, and that is where all the equation goes wrong. So if you see, look at this particular picture where you see that energy intake, if it's more in the form of high calorie food, or if the patient or if the child is not moving at all, and there is no expenditure of the energy consumed, then the entire energy derived by food is going to be stored as fat. And that is where the problem, why these patients or these children start putting on weight. So if you see the amount of energy the patient or the children can have, in the form of noodles, in the form of burgers, in the form of fast processed food, in the form of sweet. So what happens? The energy intake is so high, and these children are not going to the ground. They're not moving at all. The physical activity is very low. They are hooked to the screen. They are on the couch watching televisions, and there are no physical activities. 100% these kids are going to have a good amount of fat, and these kids are going to be obese for sure. So that's the basic difference, why there is weight regain or there is weight going up on the scale because of deposition of fat, and there is no energy outside. If you see also, there are a lot of advertisements which you will see which are oriented, or they are more increasing the amount of food, or they are just propagating food, and the advertisements are also targeted for children. Even if I can give my example, my kid is when I see my kid watching television, I see the programs what they come, or the games which she plays. It is also always concerning about how to prepare a cake or how to have cookies. It's concerned about ice cream. There's an ice cream truck. There's an ice cream parlor. They are making cookies. They are making ice creams all the time. So even the games and everything, advertisements are also focused towards food, and they are completely processed foods. They have large portion size also. There is increased frequency of eating away from home, I said. And in a specific city like Bombay or Calcutta or Pune, all those metropolitan cities, you would hardly see a ground wherein people can go, and there is no easy access to the playground. Now, only when you see playground is on Sundays, or maybe the school has a holiday. That is the time the parents can take them to the ground and they play in the ground. So you see the amount of the workload which they have even after returning from the school. They are hooked to their iPads, or they are doing some kind of an work which is supposed to be done as kind of a homework. So what happens is the child is completely confined to the house, and during the eating, probably he might or she might just watch a television, because that is the only time where they have a screen time. So when you look at a television and eat, you tend to eat more. And this is always seen in kids. They are not hungry, but they want to watch that particular time for the TV, and they will ask for more food. So that is what is happening. And overall, when you see all those things, there is decreased physical activity. Because of all these things, they go into a vicious cycle. So the child are always healthy. The child is always a healthy child. Over a period of time, because of no physical activity, or because of all study and there is no play, they become mildly obese. As they go up on a moderate obesity chart, what happens? Their activities inhibit. They are tired to take the stairs. They would always prefer to take the lift. Their physical activity goes down. As they put on a little bit of more weight, as they move towards severely obesity, their exercise becomes uncomfortable and painful, and that is where they start having a very sedentary life. They are less active, and that's where an obese adult is born. And when this happens, early onset diabetes, early onset dyslipidemia, PCOD, a lot of other problems. So if you see in this slide, what data had mentioned, that at least 30% of 30% of obesity begins in childhood, and conversely 50 to 80% of these obese children become obese adults. So if a kid is obese, there's a 50 to 80% chance that that same kid would be an obese adult in future. So that's really, really important to understand, that obesity starts in childhood and it would end in an obese adult, and that entire comorbidity, the entire comorbidities would also be followed, and that problems will always be continued in the childhood and in the adulthood also. So there are implications as well, because when these kids do have a higher side of the weight, and they are more on their weight, and their scales are higher side. So there are physical implications, there are emotional, and there are social implications also. Physical, the most important thing is the insulin resistance. So the blackening around the neck, which is always considered a very small thing, but that's a predictor for diabetes in future. So insulin resistance, type 2 diabetes at an early onset, hypertension, cholesterol, hepatic steatosis, cholelithiasis, sleep apnea. So the list goes on and on and on. So these all problems which are supposed to be an adult onset problems would start in an early age if the child is on obese side. 100% emotionally this child will be shattered, because they would have a low self-esteem. because they, when you go to the school, they would see other people looking thin, moving around more nicely or in a more energetic manner as compared to them, because they have a negative body image, they have depression. Plus, there is bullying. There's always a discrimination of people who are on higher side of the weight. So these are the problems which these kids will always face. This is a chart wherein all the problems related to obesity in children has been mentioned on this slide. So there are some complications also. So if you see that if the BMI is above 95th percentile, the risk of CVD mortality is increased by 3 to 5 times at the age of 50 years. Adolescent with type 2 diabetes show a decline in beta cell functions in the pancreas, which is 4 times faster than that seen in adults. So the diabetes or the early onset or the adolescent diabetes is far more dangerous as compared to the beta cell functions as compared to the adults. Insulin resistance in adolescent is more severe than in adults. The severity of OSA, again, children with OSA experience increased mortality and morbidity independent of other risk factors. There's a strong association between childhood obesity and increased risk of pediatric idiopathic intracranial hypertension. Blount's disease, slipped capital femoral epiphysis are the disease associated with childhood obesity. Yes, there is prevention. Prevention is always better than the problems which these people would always face if they are obese. So, multiple ways we can prevent obesity. Now, the commonest thing which we can do is set a good example. If the family, probably if the parents, they have a healthy life, they are used to exercise every day, they do not order a lot of food online, or they do not go outside to have food, what the child will see is they would see that whatever the parents are doing, that is only right. So if they have a healthy lifestyle, the child will also have a healthy lifestyle. So you set an example for your kid, you take the responsibility. The same thing would be incorporated in your child's behavior also. Have healthy snacks. Always include options such as air popcorn without butter, fruits with low fat yogurt, baby carrots with hummus, or whole grain cereal with low fat meal. So these are a couple of examples I'm giving. There are a couple of more which I would be giving. Often offer new multiple food items. So once your child rejects that particular food which is healthy, probably you feel that is healthy, and you offer a kid, your child is not taking it, don't get disheartened, because it takes 10 or more times for the food to be accepted, and this is as per the studies. So if your child rejects the food for 5 times, do not get disheartened. At least try for 10 times on different occasion, then the food would be accepted by the kid. So this is as per the literature as well. Include a lot of fruits and vegetables. Have a rainbow color plate method. Multiple fruit with different colors you can add to your plate, so they get tempted to eat those healthy food and the fruits as well. Opt for whole grains or over refined flours. Encourage eating of brown rice, quinoa, oats, broken wheat, or brand fortified products. Restrict the use of refined flour products like cake, muffins, naan, bakery products. See, what happens is when you are so there's a difference between a simple carb and a complex carb. Now, simple carbs are your all bakery items, sweetened colas. So when you have those simple carbs, they remain in the body for a very shorter period of time as compared to complex carbs such as oats, banana, fruits, vegetables. What happens, these carbs, the complex carbs, stay in your body for a longer period of time, and they achieve a longer time, and the patient, the kids, they feel full for a longer period of time, and that is why the complex carbs are are much better than the simple carbs. So replace your all fatty food with dairy, eggs, poultry. Substitute whole fat milk with products such as low fat products. Low fat smoothies always are to be considered when you consider the high calorie sugary shakes or ice cream. Eliminate soda and aerated drinks from the diet, and offer smaller portions. See, what happens is when the child sits for having his lunch or dinner, the parents would pour everything on the plate, thinking that no, he will have, because if I give small portion, then he'll eat only less and they'll not ask for food. But that's wrong. Offer smaller portions. Let the child ask for food. When the child asks for food, he knows what is hunger, and he knows how much the body wants and how much, by how much quantity the body would be full. So always do not overfill the plate. Give smaller portion. Let the child ask for food, and that is how the food should be given to the child to prevent obesity. And experiment with herbs, spices. use herbs, spices such as mint, cinnamon, allspice, and nutmeg to add some sweetness rather than putting more sugar or jaggery for that matter. And these are all empty calories. And always stock your fridge with healthy options. If there is nothing unhealthy, or if you do not store any cookies or chocolates at home, the child will not be exposed to that. The child will not ask for it. So you keep an exposure, you keep things at home, the definitely child is going to ask and cring and cry about having those sugary sweets. So stock your fridge with healthy options, reduce the frequency of eating outside meals, consume home cooked food on a more daily basis, discourage eating in front of TVs. The screen time, see, the screen time, if you want to give a screen time, give it at the time when the food is not there on the plate, or probably not during the lunch and the dinner time or the breakfast time. So you restrict the amount of TV, and also restrict eating while watching TV. There are more healthy options such as fresh fruits, fresh juices instead of canned juices and fruits, or for low fat yogurt. Include a lot of fresh vegetables, and you can also cut vegetables in different shapes. So that also gives a lot of happiness, and they can start eating food as well. You can give air popcorns also without butter. So these are a couple of healthy snack options for your children. And there is a prevention also in the form of, let's say, what happens, the kid doesn't eat some kind of a food, but you will always say, oh, you have this food, or maybe you complete your homework, I'm going to give you a candy or some ice cream or chocolate. So never reward any unhealthy thing. Always remember that promising candy for good behavior is always a very bad idea. And sleep, again, it's really important. Too little sleep may increase the risk of obesity. So sleep deprivation can cause hormonal imbalances, and that can lead to increased appetite, and that again leads to obesity. So what options do we have apart from prevention also? Now the patient is, what I see, the kids are already above 130 or 100 kgs, and they are indicated of surgery. So metabolic and bariatric surgery still remains the mainstay of obesity. It can be indicated in idiopathic intracranial hypertension, NASH, Blount's disease, GRD, hypertension, or for patient or children whose BMI is above 40 or 140% percent of the 95th percentile. So these are the indications for bariatric and metabolic surgeries. And there are some contraindications as well. If the patient is having some psychological disease wherein they won't be able to maintain that diet after the surgery, then you should not be considering surgery as an option. Or if there is an ongoing substance abuse, or there is a medically correctable condition wherein you can put on medications and then that things can be settled down. Yeah, these are the contraindications. But there are some strong indications also, such as if there is a CVD risk factors, that should always be considered a strong indicator for bariatric and metabolic surgeries. Childhood onset type 2 diabetes, which is failing medical management in more than 50% of cases. So childhood onset type 2 diabetes and insulin nutrition should also be considered a strong indicator for bariatric and metabolic surgeries. In adolescent, they result in significant improvement or resolution of OSA, so it should also be considered a strong indication. Non-alcoholic fatty liver disease, complete resolution of NASH is approximately seen in 85% of children who have undergone sleeve gastrectomy or RYGB. So that's again a literature backed up for that. Adolescents who suffer from severe obesity, have failed medical management of intracranial hypertension, should also be considered for bariatric surgery. And you also see if there is GRD, then RYGB does play an important role for resolution of RYGB. Now, once the surgery is done, this adolescent, they have a significant improvement in the quality of life when there is marked sustained improvements in relation to surgically induced weight loss by 5 years, a lack of other options in children with Prader-Willi syndrome or other syndromic obesity or hypothalamic obesity. Metabolic surgery should be considered, especially when comorbidities exist. Now, considering Prader-Willi syndrome, I would give you an example of a patient who was there with me. So, this patient, she used to sleep like this. She's only 14 years old. I mean, now she is 17 years old. But that time when we planned, or when I saw her in the OPD, That's the photo shared by the parents. So this is how she used to sleep. She used to sit on the floor, take the sofa as a for a backrest, and that's how she used to sleep. The reason, because of severe obstructive apnea. Because the time she used to lie down flat on the back, the respiration used to go for a toss, and she used to be getting awake. So she found out that this is the easiest way of sleeping, and since years she was sleeping like this. So when I saw her for the first time, she was only 14 years old, 143 kgs, BMI of 66 at the age of 14 years. Definitely with that BMI, these kids will have an early onset of obstructive apnea. So she had severe OSA, depressed. She was not even looking at me in my eyes. She was just looking some in a different direction. And when I was asking any question, she was not even nodding or not even giving me a response. And she had fatty liver, dyslipidemia. So all those things, when I actually evaluated one by one, I came to know that these are all the problems she is having. She had inability to walk because the weight was so much on that small knees that she had developed a genu varus deformity, and because of which she was operated also for the deformity. And when I worked her up, she was negative for a Prader-Willi. Genetic workup was completely negative. I involved a pediatric endocrinologist also. They did all the fish tests and everything, but it all was negative. And yeah, so the fact that the parents actually thought of doing something for the kid, was very happy that at that early age the parents were so much into weight loss that they wanted to do something for the kid because they couldn't see the way weight was going up. So when I counseled them for surgery, they agreed to that, and we did a sleeve gastrectomy for her because she was too young for a bypass. Ideally, a patient of 143 kgs requires a pediatric bypass, but she was too young for that, and we did a sleeve gastrectomy on her. She's at that time, this is an old data, but she lost 34 kgs within 4 months. She started sleeping properly on the bed. School became a regular thing for her. Started going for walks, and then she knew that there is some probably an option wherein she's losing weight, and that gave her a lot of confidence. And she was really happy with what the new journey she just embarked in. And that was the thing, because she was the youngest patient to undergo bariatric surgery in the district of Thane. That was covered in Times of India also. So there's a literature which says that if you have a lot of years of exposure to obesity, like state, which contributes early mortality in patients with childhood onset obesity. So if you're exposed to obesity since childhood, there is an increased chance of early mortality in adulthood. Therefore, early intervention may decrease the mortality in adolescent undergoing bariatric and metabolic surgery. So, like I always say, together we can and we should fight obesity. That's my team, because it's not a single person's job. And you do require a big team to help you with the surgeries also. And I thank you everyone for having devoting me the time and allowing me to speak on a topic which is really close to my heart, which is childhood obesity. Thank you so much. Thank you.
Thank you so much, Dr. Prashant, for that wonderful presentation. We have a few questions from the
Yes,
audience,
yes,
so
yes.
let's go through them one by one. So, my first question to you is, could you share your perspective on indications, age, criteria, and outcomes of bariatric surgery in younger patients? Many families actually hesitate when bariatric or metabolic surgery is considered in adolescents. So, could you share your perspective on indications, age, criteria, and outcomes of bariatric surgery in younger patients?
Yeah, correct. So, when you go with the literature also, it is said that between 16 years to 75 years we can do the surgery. But that patient which you saw, she's fully 14 years. Now, for a patient of 14 years, if the patient is of that weight, like 143 kgs with BMI above 60, there is no other way out apart from surgery. So, if I consider as per the definitions, if the BMI is above 35 or the BMI is 40, these patients do really good with surgery. So, indications are there. There are guidelines based on which we can do the surgery. Like I said, 35 and 40 BMI. So, if the child is about 35 and 40 BMI, and at 35 BMI, also the patient has early onset diabetes, dyslipidemia, cholesterol, PCOD, then these patients do become a candidate for bariatric surgery. Now, when I see patients, these kind of patients in the OPD, I always see there's a lot of resistance in the family from other family members, like this, she's too young or she is too young to undergo major surgery like that. But considering the literature, considering the amount of problems would be multiplied by the time they become adult, that's really scary. And these patients, these obese kids, when they grow up, they always carry that burden till adulthood. And if you see what literature, which the papers which I have submitted, that these patients will always have higher mortality rates when they become adult if they had adult single childhood onset obesity. So it's really important for all parents to also understand that surgery is what do you say? It's not a shortcut. It's some life-changing experiences these patients will have after the surgery. Their comorbidities will go down. They will have a much healthier adulthood as compared to the same weight if they carry in their adulthood. So I would rather urge everyone to really, really go through all the literature available. If not, take an expert opinion. Not necessarily that you have to undergo surgery all the time, but at least get that BMI evaluated, understand where your child stands on the obesity classification, and based on that, get those changes made in the family. Prevention is always better. But for someone who is 143 kgs at 14 years, there's no question of prevention. The problem has already occurred, and the only best available solution would be surgery.
Thank you for that answer. Moving on to the next question. So my next question to you is, for general physicians who may not specialize in obesity management, what are the first line interventions that should be recommended before referral to a specialist?
No, for general physicians also, I would rather say that every general physician, whoever sees a patient or kid who is little higher on their weight, just by saying that no, you need to cut down on your calories, that doesn't help. You need to get their body fat analysis done. You need to get the BMI charted. You need to know where the child stands, whether it is the one, whether the patient is obese or the patient is overweight. Once you know that the patient is either overweight or obese, then you start about prevention first. Prevention by educating the parents, by educating the kid also. So it's difficult for kid to understand, okay, he doesn't want to eat, he doesn't want to do that. But then the parents are always the first hit the parents take. The parents have to be educated well. And if that is the question where the patient, like a patient who is above 40 BMI, and the patient, general physician has seen the patient, that patients can be directly considered as a surgical candidate and can be driven to a bariatric surgeon. But for example, if the patient is in overweight category and patient is not a surgical candidate, then we still have options such as medical management. Now, like the injections which have been launched in India, which are legally allowed to be prescribed for chronic weight management, that can be prescribed above 18 years of age. But for adolescent, the the data is, the research is still on. Probably by 1 year or so, we would have the guidelines to even start these medications, and younger kids also. So if you see someone in your clinic, address the problem, try to prevent, give them information about prevention, and then direct them to the concerned specialty for any bariatric physician, a child endocrinologist, or if that the weight is too much, then a bariatric surgeon.
Thank you. Thank you for answering that. My next question to you is, how do you suggest doctors address the psychological aspect of obesity, such as low self-esteem and bullying in their consultations?
No, so as even as a surgeon, when I plan for a bariatric surgery, also for kids, I don't do my counseling because I'm a surgeon. I can't counsel that way as more what do you say, a specialist. So these kids have to be seen by a psychiatrist and also what do you say, a specialist who deals in these kind of patients. So always to be seen or always to be sent or referred to a psychiatrist where they are counseled properly, and not just once, but on periodic intervals. These kids have to be counseled by a proper counselor, not just a physician, or neither a surgeon can counsel kids like that. So our job is to operate or to give them medication. But for the counseling aspect, how much ever counseling we do, we can't be a specialist. But whatever we could do, we should do it, but always refer them to a child psychologist also.
Thank you for that answer. And thank you so much, Dr. Salvi, for that insightful and thought-provoking session. You have highlighted not only the clinical challenges in childhood obesity, but also the practical solution that we as healthcare professionals can adopt to bring about a real change in our communities. Your
Yes.
expertise in bariatric and metabolic surgery, coupled with your emphasis on preventive care and awareness, has given us valuable takeaways that we can apply in our day-to-day practice. On behalf of DocPlexus and everyone present here, I sincerely thank you for your time and for sharing your deep knowledge with us. A special thank to our audience for your active participation. Thanks. Together, by raising awareness and implementing effective strategies, we can make a meaningful impact in combating the childhood obesity epidemic. With that, we conclude today's webinar. Thank you once again, and we look forward to seeing you in our upcoming sessions. Thank you so much.
Thank you so much, Shithil, and thank you so much, Doc Plexus. Thank you, audience, for having me here. Pleasure was always mine. Thank you.
Thank you so much.